All right, well, thank you. And we're going to go right now to our first speaker, and this is a terrific panel, by the way. If these are bona fide experts, so I'm going to bring Dr. Robert Ramirez up, let him tell us a little bit about himself, and get right into his presentation. Dr. Ramirez.
What a great group. I'm really honored to be here in front of all of you. I want to thank Eric and the Healing Net Foundation and NCAN for allowing me to come speak to you. I see quite a few of you that I've seen in the clinic. And my background's a little bit different than Eric's. I was a professional lung doctor before I started doing neuroendocrine, so I did the exact opposite of Eric. My background was actually in thoracic oncology. But when I moved to New Orleans, they said, well, you know what, we run this thing called the neuroendocrine clinic. And I said, okay, well, I will learn all about neuroendocrine, and that's what I've done. But at the time, they were excluding all of you. They said, yeah, we don't really see a whole lot of lungs. And me being a thoracic oncologist, I said, no. We need to capture these patients. These patients represent 30% of neuroendocrine tumors, and it's not right to exclude all of you. So now we have a very good practice. All I see is neuroendocrine and lung. I don't see breast or colon or anything else. I see two different types of tumors. So it's nice to be able to do that. So what I've been tasked to do is talk to you about the basics of neuroendocrine. Now, many of you, I'm going to cover a lot of things that you guys already know, and I hope to elaborate on many things. So why we are here today is because of you. There's a lot of misconceptions in the field, and hopefully you'll walk out of this conference later on today with a better understanding of your disease. So you have a real cancer. By a show of hands, how many people have been told, oh, you don't have a real cancer, you don't need to worry about that? So we recognize that. I didn't say you don't have a real cancer. So you're a zebra. I don't think I need to explain that to anyone in this room. You've got a disease that's poorly understood and is not well studied. So when we talk about research dollars, we're sort of at the bottom of the barrel, unfortunately. So what I'll talk about today is I want to define quite a few things. I want to talk about the epidemiology of lung cancer in general, and why your lung cancer is different than other lung cancers, why your lung neuroendocrine tumor is different than other neuroendocrine tumors. I'll talk about the basics of diagnosis. I know you've got other speakers that are going to go much more into it than I will, the basics of treatment, and I'll take time to answer some questions. So I know many of you, this is very, very basic, and I think this is important to point out. When we look at our trials, when we run our clinical trials, we have a goal in mind. And we say, what are we looking for? And it's very important to define that up front. And if we're looking, when we're testing our drug or testing whatever treatment we're doing, we're looking for, one, overall survival sometimes. And what that is defined by is survival from the enrollment until death from all causes. Sometimes we look for something called progression-free survival. And that's the time from enrollment until the time the treatment stops working. And then we look at response rate, and this is a very strict definition. So when you hear docs get up and say, oh, the response rate was this, or I'll try to say what that is. And then what goes underlooked a lot of times is we need appropriate statistics on everything. So when I read a journal article, I pick it apart and say, well, was this a well-designed study? Because so when you're out reading these articles and you get copies, and I want to be able to, hopefully you'll be able to take some of this with you. So this is one of the things that you see on our in our journal articles. This is called the Kaplan-Meier curve. So what this looks at is on the x-axis is time, and then on the y-axis is the proportion alive, or in this case, and I'm sure you're going to see this later on today because this is the data for Affinitor. So what we really want to point out with this is the separation of the two lines here. So you can see on the green is above the brown. And what that means is that the patients in the green did better than the patients on the brown. So each time one of those lines drops off, an event happens. So either the patient progressed or they died. And then we look at something called the hazard ratio, where right there on the bottom it says HR 0.48, and that is the percent benefit that the patient received. So 52% of the patients were progression-free compared to the placebo group, which is the brown. So sometimes our Kaplan-Meier graphs look like this. This isn't truly impressive. We say, all right, well, neither one of these treatments really work. So that's something to point out. What does it mean to respond? So there's very strict definitions. Complete response, your disease is gone. Partial response, a decrease in volume by 30% or more. Stable disease, either a decrease above 30% or less than 30%, or an increase of less than 20%. So you're in that window is stable, and then progressive is above 20%. And we look at things like this called a waterfall plot, which on the x-axis is the baseline response, or where you started at, and anything underneath is each one of those lines. They're hard to separate, but each one of those lines is a patient, and their maximal response. So anything below is a response, but again, keep in mind that 30% to really be defined a response. So, and then we talk about toxicities. We can't do anything without looking at toxicities, and there's very strict grading criteria, but in general, grade 1 is minor and asymptomatic. It's something we see on a lab. Grade 2 is minor with symptoms. 3 is major with hospitalization. 4 is life-threatening, you're in the ICU, and 5 is death. So when you look at when you read these articles and people say there were X percentage of grade 3 and 4 toxicities, this is what they're talking about. So let's talk about lung cancer incidence. And so lung cancer is, you can see right in men, the second leading cancer, and in females also the second leading cancer. And this is all comers. But if we look at that incidence, if we look at lung cancer in general, it is the deadliest cancer in the world, including the U.S. So about 160,000 people will die each year of lung cancer. It kills more than breast, colon, and prostate combined. And you can, if you put pancreas in there, you're right even as well. So surgery may be curative for early stage disease, but many people, by the time they get to us, only about 25% are actually surgical candidates. But when we look at the lung cancer incidence, we break it into different types of histologies. So there's something called non-small cell, which is the big blue piece of the pie, and then we have small cell, which is the red piece. Now this is a form of neuroendocrine cancer, and we talk about large cell neuroendocrine, and in the green, the little tiny slice in the green is carcinoid. So it represents about 2% of all lung cancers. And this is a very broad spectrum of disease, and we define it, we have very strict definitions, and things are still evolving, but we break it into typical and atypical. I know it's somewhat archaic, as Eric pointed out, but also large cell and small cell. And and it's defined by morphologic and basically what it looks like underneath the microscope. And so this is a classification. I'm sure many of you have seen this before, or you may see this again later on today. And basically, so these are the four types. So typical, atypical, large cell, and small cell. But what I want you to focus on is this, and this is what we really define this when our pathologist looks at this under the microscope, the mitotic rate, and also is there necrosis. So if there's no necrosis and less than 2 mitoses, we call this typical. If there's more than that, we call it atypical, or if there's necrosis. And then when we go to the other side of the spectrum, we have large cell and small cell, which is extensive necrosis, high, very, very high mitotic rate. And these are classified differently than our GI nets. So in the GI world, we say grade 1, 2, and 3, and it's based off of the mitotic count and then something called the Ki-67. And how many of you know your Ki-67? So there's something to be said that, you can see, I showed you the Kaplan-Meier curve and what that means. So your grade 1s are on top. They do much better than the grade 2s, who do much better than the grade 3s. But it's different. Lung is not classified by Ki-67. However, we think maybe in the future one day, Ki-67 may be useful. So this is a study that looked at this. They looked at Ki-67s less than 5%. That's the bar on top, and then Ki-67s under or over 5%. That's the bar on the bottom, and you can see that the low KIs in lungs do much better. Now, what if we break it down into typical and atypical? So Ki-67 of 5%, less than 5 in typical, and that's the top bar. Ki-67 of more than 5, and that's also typical. That's the bar in the middle, and then the atypicals on the bottom. So again, this is an evolving role, and in our data, we looked at close to 170 neuroendocrine tumors of the lung, and also found a very similar pattern. But we broke it down in a little bit different. So the blue bar is a Ki of 0 to 2%. The green bar is 2 to 10%, and then the red is more than 10. So we think that it's useful. Each one of our patients that comes and sees us gets a Ki-67, even though it is not part of the grading of these things yet. So what I will say is Ki-67 can change over time. This study looked at over 300 patients, and at the time of progression, some of these patients had biopsies, and it turns out over 35% of the time, the Ki-67 changed, and 75% of these patients actually had upstaging. So I think we've all seen patients who are cruising along, doing well, stable disease, and then all of a sudden something happens, and when we rebiopsy, this is what we see. So what are the symptoms? Well, cough up blood, shortness of breath, wheezing, all of these pulmonary things that you would expect to see with lung cancers. But guess what? Many times this is an incidental finding, and someone does a chest X-ray for various reasons, and there's a mass, and that's what gets the ball rolling. So what's our initial workup? And I'll kind of go through this quickly because I know you're going to get a lot more of this. But it generally starts with a chest X-ray. You can see on the left there's a mass, which leads to a CT. Again, you see this mass that's in the left upper lobe, and then this follows up by PET. And I'll talk about that in a little bit. Sometimes we need an MRI of the brain. and then I'll talk more about an Octria scan and the role of gallium-68 PET scan. So the bottom line is that all those imaging studies, they tell us something's abnormal. What we need is tissue. We need a biopsy. And what this requires is a multidisciplinary approach. How best to get the tissue and the highest yield and the safest for the patient. So we use our pulmonary colleagues, our medical oncology, thoracic surgery, interventional radiology, and pathology. And sometimes we have to get our neurosurgeons or orthopedics involved as well, depending on locations. So some of the diagnostic procedures that I'm sure many of you have gone through, bronchoscopy, this can allow for washings and cytology and also endobronchial and transbronchial biopsies, a mediastinoscopy, which I'll talk about here in a little bit. The newest one on the block is an EBUS, or an endobronchial ultrasound. This allows the pulmonologist to see through the walls of the bronchus and biopsy lymph nodes or tumors. Thoracentesis or pericardiocentesis is where it's actually a needle placed in for fluid, and we take fluid out. Sometimes a CT-guided biopsy, and sometimes we actually need to do an open biopsy. So this is a cartoon of the lung, mediastinum. So 3 lobes on the right, 2 lobes on the left, and all these little dots represent lymph nodes actually. And what you can see is this is what I want to call your attention to. This is our first order of lymph nodes. This is our second order of lymph nodes, and our third order of lymph nodes. So we say N1, N2, and N3. You don't necessarily, there's much stricter definitions for things, but I just want to call that to your attention because it's going to become important in the subsequent slides. So how do we get there? How do we assess all of this? Well, yes. Normally we have a mouse that would help out, but okay. So this is a cartoon of a mediastinoscopy. So basically, it's an incision up in the neck here, and they can put a scope down and pull out some of these lymph nodes. This is an EBUS probe, and I'm sure you'll hear more about that. Again, it's an ultrasound that allows you to visualize things outside of the bronchus and allows biopsies that way. So, and I'm not gonna test you on all of this, but we have staging that can get very, very complicated. And my residents and fellows, I say, all right, well, you need to know this because this is all on your boards, and this is lung cancer staging. We stage it based on something called TNM, so tumor node metastases. So there's very strict definitions. So T1, T2, T3, etc. N staging, again, is there lymph node metastasis? N1 means hilar lymph nodes. N2, middle of the chest, mediastinal, or N3 is up in the neck or on the other side of the mediastinum. And then metastasis. It's pretty self-explanatory. And then we come up with this big complicated thing, breaking this into anywhere from stage 0 to stage 4, and then all of this in between based on your TNM. And you don't need to know all of this. What I would say, there's some generalizations. So stage 1 is confined to one location in the lung. Stage 2 is one location, and then metastasis to that first set of lymph nodes. Stage 3, one location in the lung, and second or third level of lymph nodes positive for disease, and then stage 4 is distant disease. And so why do we even care about staging? Well, it impacts prognosis, and it also gives us ideas on what we do for treatment. So that's the big thing. And when we look at prognosis in neuroendocrine tumors of the lung, we see our typicals, stage 1, do better than atypical, do better than large cell. But if we look at all stages, same thing. So, and that's those curves separate pretty nicely. So this was a paper of all neuroendocrines. So if your tumor was localized, you did better than when it was regional, and certainly better than if it was distant. Now this is somewhat smaller, but you can read this in your handout there. The survivals that based on the large national database. How did we do? So same kind of thing. The stage 1s did better than stage 2, did better than stage 3, did better than stage 4, and this is based off of our data. Same with typical and atypical, 5 and 10-year survival rates, very different. So let's talk a little bit about carcinoid tumorlets. These are things we're not quite sure if they mean anything. We see this in various, we see this with carcinoid tumors. We see this with something called dip-neck, which is what I'll touch on here in a little bit. But you can also see it with various inflammatory conditions and other fibrotic conditions. And the thought is they don't really mean a whole lot. They're there, but we don't know if they're doing anything. We don't think that they're precursors to anything, but sometimes we see them. So let's talk about dip-neck, or diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. So big long word that many of our pulmonary colleagues and elsewhere have never heard of, but I think it's becoming more and more recognized. So it's very rare. In fact, the largest case series was just published, I think last year, had 30 patients in it. So this is a proliferation of the neuroendocrine cells limited to the basement membrane. It tends to affect women in the 5th to 6th decade of life. We do think that, unlike tumorlets, that this is pre-neoplastic, and it can present with carcinoid tumors or tumorlets. The symptoms of dip-neck are generally cough and shortness of breath that can go undiagnosed for a number of years, and people get misdiagnosed with COPD or asthma, and then someone says, oh, let's do an X-ray or CT, and you see these pulmonary nodules. And these, and then somebody does a biopsy, and that's what it shows up. So this is a group of 19 patients that had dip-neck. And what I want to point out is this. So the mean duration of illness prior to the diagnosis, 8.5 years. So people suffer with this for years and years and years, and then somebody finally says, oh, by the way, you have this. And so how do we treat it? So sometimes symptoms are not severe. We don't need to do anything. We know it's there. Sometimes, I have a lot of patients who have come in and they've been on steroids and inhalers with varying success. Somatostatin analogs are maybe beneficial, and I'll talk about that in a minute. In severe cases, lung transplant has been used. So this is a paper we published last year that looked at patients with dip-neck, and there's 5 patients here, and if you look, 4 of them ended up with somatostatin analogs. All 4 of them ended up with either symptom resolution or improvement in symptoms. So now again, this is not a prospective study, but this is, as far as I know, this is the only evidence in the literature about somatostatin analogs in DIPNIC. So, so it's something to consider. So let's talk about typical and atypical lung carcinoids. We divide them into, there's a 9-to-1 ratio. So majority are typical. There's no, that tends to affect men and women equally, and it can occur at any age, sometimes, but with an average of 45 to 55 years. But it is the most common lung neoplasm in children and adolescents. So again, I touched on imaging here previously, but I want to go back and talk about some of the nuclear medicine imaging. So there is some misconceptions that we don't need to do PET on patients. I do get FDG PETs on patients. In our series, 80% of the patients actually had some uptake on their PET CT. Now, when I look at my patients with non-small cell adenocarcinoma, we look at something called a SUV max, or standard uptake value. Now, the higher, the more aggressive the tumor generally is. So non-small cells, I see them 15, 20, 25. With typical carcinoids, the SUV max is about 3.5, and atypicals, it's a little bit, it's higher. So we use octreotide scanning. However, again, in our series, we found only 50% of our patients had uptake on their octreotide scan. So that can limit some of your treatment modalities as well. And then the newest one on the block, as I'm sure you're all familiar with, is the gallium-68 PET. And I'm sure you have seen this picture. We're very excited about this. On your left is your octreotide scan, and if you squint your eyes and turn your head a little bit this way, you can say, oh yeah, there's some tumors in the liver and maybe elsewhere. But then on the right, you see that very, very clear picture of where everything is. So that's very, very helpful. So biochemical assessment. So we will get labs on patients, including a chromogranin or a pancreastat, and we look at the kidney function and the calcium. Sometimes we'll get a 24-hour 5-HIAA, or the newest one is a plasma 5-HIAA. If carcinoid syndrome is present, sometimes a serum cortisol or a 24-hour urine-free cortisol. If depending on symptoms, growth factor releasing hormone, again depending on symptoms. And now the newest one is gene expression profiling. But what I would say is all of those markers we get are somewhat controversial, and I think the field is evolving. So I think stay tuned. There's in lung there's not. I think some we can follow with markers, some we can't. So stay tuned. So I talked about this already as far as the frequency of pulmonary carcinoids, and 90% typical and 10% atypical. What is interesting is node positivity at presentation is 15% in typical, and then 40 to 50% in atypical. So again, this goes into stage, and then distant metastases at presentation. 3% of typicals present with distant disease, and up to 20% of atypicals. So they're definitely two distinct diseases. And we call them low-grade tumors, but again, as I said initially, these are real cancers, and we need to treat them as such. So even in this series, the 5-year survival after surgery, a curative intent surgery, was only 60%. So, and the mediastinal nodes, they are prognostic. So we need to treat them accordingly. So what are our treatment options? So sometimes it's primary resection, and in some cases, if this recurs again, we go back and take it out again. And then on my side of things, being a medical oncologist, So I use chemotherapy. There's some targeted therapies like Afinitor. Radionuclide therapy, I think, is coming along. We use a lot of liver-directed therapy. I know you're going to hear a talk about that later on today. Somatostatin analogs in clinical trials. So first, second, and third line therapy. Patients come to me. I send them to the surgeon. If they don't have distant disease, yeah. I say you don't need to see me. You need to see my surgical colleagues, and then come back and see me. But yeah, that is the big thing. And I've heard so many stories about, oh yeah, we're just going to watch this. We don't need to do anything. We're going to watch it, and then I've seen disasters after that as well. So anyone who says surgery is not the best, go find another opinion. So what about beyond surgery? So there are a few prospective studies designed for lung. So the data that we have comes from lower levels of evidence, like case series and case reports. And we know that patients who have node-positive disease, so either N1, N2, or N3, do worse. And in our non-small cells, guess what? If you have node-positive disease, if it's an N1 at the time of surgery, you're getting chemotherapy afterwards. If it's an N2, you're getting chemotherapy followed by radiation to the mediastinum. But in this is much different. So there's no standard treatment. Can we use somatostatin analogs as an adjuvant treatment or treatment after surgery? Can we use chemo? Do we watch and wait? I think we need trials to tell us what to do. So this was a retrospective study. So they looked at this is from a Spanish registry from 1980 to 2009 on 127 patients with atypical carcinoma. And what they found was no difference in survival in those patients who got adjuvant chemotherapy versus those who did not. But what they did find was a worse prognosis with what we call sublobar resections, or and I'm sure you'll talk about the different types of surgery. So we think maybe a sublobar or a wedge resection is not good enough for this type of disease. And the prognosis is dependent on staging. So this is our Bible, our NCCN guidelines, and this is a group of oncologists and other people who take care of lung tumors. They come together and come up with guidelines that we should follow, and this is available to all the community doctors. And what I want to point out is a couple different things. Is if you look at at the top where it says stage 1 through 3, it says surgery, lobectomy, and or anatomic resection and mediastinal lymph node dissection. And if you go down to, it breaks it into low grade or intermediate grade. And then I want to point that out. So your adjuvant therapy with cisplatin and etoposide plus or minus radiation. Okay, so I also want to point this out. In the very little letter, the very little fine print at the bottom, it says no substantial evidence to do for any of these regimens. So it should be. In these slides, I apologize, the ones I'm showing here may be a little bit different or out of order as I revise some of these. So, but there's no difference or no substantial evidence. What about progression? So do we use a somatostatin analog? Do we do chemo, targeted therapy, radionuclide therapy? Well, I think the data with somatostatin analogs is, again, still evolving. This is a series. If you look in the box anyway, these are all different trials. And the ones in the pink box, they had included neuroendocrine tumors of the lung. So there's no specifically designed trials of just with lung neuroendocrine. But you can see an overall response rate in stable disease in 28, 57, 43% of patients. So I think they do play a role, and I think, stay tuned. There is a clinical trial examining this now. So what about chemotherapy? So for carcinoids who progress, again, I said platinum-based chemotherapy is recommended by the NCCN, and the majority of patients will get cisplatin and etoposide. Well, so this is a series of four different trials that looked at patients with carcinoid tumors who got cisplatin and etoposide, various years, various tumor types, and you can see the response rates are varied. So 7% for a well-differentiated, 9%. There's one outlier that 56%. And even in my adeno and squamous cells in the metastatic setting, I look for about a 30% response rate of chemotherapy. So it just doesn't work that good. The newest one is combination capecitabine and temozolomide. In this study, they looked at 29 patients, and 8 of them had lung carcinoid. And what they found was the majority of them were pretreated, and it turned out that the majority of patients actually did have disease control, so a disease control rate of 72%. So I do think that this may be beneficial. And when we talked about toxicity, thrombocytopenia or a decrease in the platelets was the most frequent grade 3 toxicity. So how did we do? We just published this last month. In our series, we had 4 patients who had lung nets, and it turns out about 50% of them had some sort of clinical benefit. So we're still wondering, well, is this as good? You can see the clinical benefit in rectum and pancreas and small bowel, it seems to be better than it is for lung. And it seems to, again, as I pointed out, Ki-67 also played a role in that. So what about progressive other chemotherapies? So this is FOLFOX is a type of regimen we use in colon cancer. There's a single case report of FOLFOX and bevacizumab or Avastin that looked promising. I have used this with patients before. But again, low levels of evidence. And then you're going to hear all about this one. This is the Afinitor data. So the 52% reduction in relative risk of progression or death with Afinitor versus placebo. What about PRRT? Again, no trials designed specifically for lung, but what I want to point out here is very, very, very long progression-free survivals. So you've got one that looks at 40 months. So that is, we're very excited that PRRT is on the horizon. Now, whether or not this as you may know, this trial that's going to have this approved was done in small bowels. So whether or not this translates into the lung world or the pancreas world, we'll have to wait and see. So this is just some images, and you can see the before and after. So let me point out, so you can see that down, and you don't see it there, and then this mass in the liver, and so you can see a response there. There is another type of radionuclide therapy called MIBG. This is data we presented at the World Lung Conference last year. This was 6 patients with lung carcinoid, and most of them were heavily pretreated, and it turned out we had about a 50% clinical benefit. So let me take just the last few minutes and talk about small cell. This is on the spectrum of neuroendocrine, very, very high grade. Still over 30,000 people diagnosed in the U.S., but very, very chemosensitive. But most of them will eventually die from this cancer. So it's rapidly progressing. The doubling time can be anywhere from 25 days and up. So when I see it, I put people in the hospital and I get them started on treatment. So we use a little bit different staging. We do limited staging versus extensive staging, and it has to do with if we're going to be able to use radiation or not. If it's limited to one area and I can fit all of my radiation in there, it's called limited stage. If it's gone to elsewhere, we call it extensive stage. And again, this is something we don't want to delay treatment on. So the NCCN recommends not delaying the onset of treatment for more than a week. So how do we treat it? We treat it generally with limited stage. It is a curable disease, low rate of cure. However, chemotherapy with radiation, and you can see the overall response rate with the combination is 87%. Median overall survival of 23%. So still, we've got work to do here. What about surgery? The problem is most of these patients, when they come in, it's already spread, and surgery does not have a role in small cell if things have spread beyond to any order of those lymph nodes. But if you have a small tumor that you catch incidentally, I think it may be beneficial. So what about metastatic disease? Chemotherapy alone, we tend to use cisplatin and etoposide. There's another trial. There's some people who will use cis and irinotecan. This was based off of a Japanese study. We were never able to duplicate this in the U.S., so I don't tend to use it. But I will say at ASCO this last week, there were two very provocative abstracts looking at the role of immunotherapy and also an antibody drug conjugate. And I'd invite you to look at those abstracts and Google those. They're very impressive for a disease that we really don't have a lot for. Prophylactic cranial irradiation is used because many of these patients will develop brain metastases, and it turns out people who get radiation after their initial treatment do better than people who do not. And this is also an extensive stage disease. So treatment if people do not progress, we will generally give them a dose of radiation after their chemotherapy. So recurrent disease, again, most people relapse, and when they relapse, it's bad. So median survival of only 4 to 5 months. And you can see the best agent we have is topotecan, and we're looking at 26 versus 14 weeks overall survival versus best supportive care. So overall, a bad disease. So it's potentially curative. You should treat it urgently. I didn't talk about paraneoplastic syndromes, but these hormonal-driven syndromes can also occur, and overall survival is poor. I will say, just take the last few slides and talk about clinical trials. We still don't know the best way to treat our cancers. So that's why we do these trials, and I want to emphasize that you are not a guinea pig if you go on trial. I always tell my patients, you have an excellent opportunity to potentially benefit from one of these newer agents. You have so many other sets of eyes looking at you when you are on a clinical trial. If everything gets done appropriately, if any of you guys had delays in your care because somebody didn't call you back, or that doesn't happen when you're on a trial. So I will give a plug for this trial. This is the SPINET trial that looks at lanreotide versus placebo in patients with lung carcinoids. So this is open this is going to be a global trial. It's open in New Orleans. It's open in Denver. It's open in Texas as well. And then there's going to be several other sites around the country. This was an interesting abstract that I saw at ASCO this year. This is from a group in Italy that looked at lung carcinoids and looked at genomic profiling. And so this is something we do in our non-small cells, and we have targeted therapy for. So this may be something promising down the line. So I'll conclude with, we talked about this being a very wide spectrum of disease, anywhere from dip-neck all the way over to small cell, and that NETs can comprise nearly a quarter of all lung cancers. Again, there are no benign carcinoids. All have the potential to metastasize and cause problems. I will emphasize there are many treatment options, albeit we need more, and clinical trials are needed. So I'll stop there and take any questions. Yes. Yeah. So So the question is about wedge resections, and I think we have a surgeon coming up to discuss this as well. So wedge resection is basically taking basically carving that tumor out, rather than taking an entire segment. The lungs are divided up into lobes and further divided into segments. So in that particular study, it looked at how people did versus if they had a wedge resection versus a segmentectomy or a lobectomy. And in that study, they said that patients did better if they had something more than a wedge. So, and that's, yep, okay. Yeah. No, that is, and nobody knows the optimal number of lymph nodes, but so the question is about mediastinal lymph node dissection, and basically how many lymph nodes need to be removed, because we don't know exactly how many lymph nodes there are in the mediastinum. So in other cancers, we know that you need to have 12 lymph nodes removed in colon cancer, for instance. In lung cancer, and especially in carcinoma, we don't know the optimal number. We do know that they should be sampled, because if they're not, we don't know the true staging of the cancer. So the question's about, are there side effects of the mediastinal lymph node dissection, including lymphodemas? No. So I guess, okay. Yep, all right, thank you.
Wow, that was quite a whirlwind of a presentation. Yeah, it's quite a whirlwind. So now what we're going to do is I thank Dr. Ramirez